Hello, I'm Ingegerd Östman-Smith from Queen Sylvia Children's Hospital and Gothenburg University, and you may wonder what I'm doing in a session on rheumatic fever, as my research interest is chiefly cardiomyopathies. However, by the dint of having had a long career as a general pediatric cardiologist, both in Britain and in Sweden, I have had some experience I would like to share with you. Like most of you, I was taught by physicians that had never encountered a new active case of rheumatic fever, and all textbooks stated that it was a disease of low-income countries, virtually extinct in the so-called developed world. Rheumatic fever was never present in the list of differential diagnoses to be considered in cases of unclear febrile illness. So I was completely unprepared when I encountered my first case of acute rheumatic fever. This is an observation chart from 1986 of a child around 5 years of age who was admitted with high swinging fever, negative blood cultures, and an ECG with T-wave changes, causing an admission diagnosis of viral myocarditis. The first cardiac ultrasound showed a small pericardial effusion, and I was tasked with monitoring the size of it daily. I noticed that day by day, the mitral valve leaflets were getting thicker and that the chordae were thickening and shortening so that mitral valve opening amplitudes were reduced. And on the third day, some significant mitral valve reflux appeared. I suggested to the general pediatrician in charge that maybe the boy had acute rheumatic fever, and was laughed at. So I went to the professor in adult cardiology, who agreed it was a possibility. So the appropriate tests were sent off, and we tested changing the paracetamol that had done absolutely nothing for his fever to anti-inflammatory doses of salicylates, as you can see here, with dramatic improvement of his fever and also on his well-being. However, he remained tachycardic. So when streptococcal serology came back positive in high titers, we upped therapy to intravenous benzyl penicillin plus prednisolone, after which he made a good recovery, with the end result a just slightly thickened mitral valve without incompetence or significant stenosis. But he was the fortunate exception. In fact, most of other cases I have encountered had a massive doctor's delay in reaching the diagnosis and had severe cardiac complications as a result. The delay ranges between 6 months to 22 years. And as you see, the patient where the diagnosis was delayed by over 20 years, who originally was thought to have just a mild myxomatous valve with minimal incompetence, ended up with severe mixed mitral valve disease, severe mitral stenosis, and requiring a mitral valve replacement in her 20s. Other diagnoses, apart from the viral myocarditis in the boy we just discussed, have been iron deficiency, poor fitness, Crohn's disease, influenza, pneumonia, sepsis, juvenile rheumatoid arthritis. In the case with a boy who went backwards and forwards to his GP for 6 months, and eventually he ended up with absolutely free aortic valve regurgitation with a provisional diagnosis of acute bacterial endocarditis. He required an emergency aortic valve replacement the same night, a mitral valve replacement 2 days later, and later on a pacemaker. He, in addition, stayed on the pediatric ITU for over 6 weeks with hepatic and renal failure, which eventually recovered. Now, the 3 later cases with delay between 6 months and 8 months in their diagnosis all had permanent damage to aortic and mitral valve function with incompetence in both, but in these cases, it's not been severe enough that they had required valve replacement in childhood. They will all, however, require valve replacements as adults. Now, important to to note is that these were not imported cases from areas where it is common. They were all native English or native Swedish children. So beware, there is a resurgence in cases of acute rheumatic fever in Europe too. Some recent examples: Northern Italy area around Bologna, 98 cases over a 13-year period, majority with carditis. Southeast Turkey, 377 cases out of those 80 in the years between 2009 and 2017. Again, majority presenting with carditis. So this disease concerns you too, even if you work in Northern Europe. Make sure to include it on your list of differential diagnosis in cases of fevers of unknown etiology, newly discovered valve incompetence, or arthritic symptoms. Learn from our experts so that you perform the correct diagnostic test. And remember to exclude streptococcal infections in all patients with sore throats. Thank you for your attention. I will now hand you over to the real experts.